right, good morning, everybody. It's 11 o'clock. We're going to go ahead and get started. My name is Joe Brothman. I'm the Director of Facilities at UCI Health in Orange. I also have the pleasure of being the education care for CSHE. So one of the events we're putting on, or we're continuing to put on, are webinars from our friends at the Joint Commission. And today we have a presentation by Herman McKenzie, who's the Director of Standards Interpretation Group from the Joint Commission. I'll be introducing and giving a short bio in just a second, but just some information about what you tuned into today. Today's presentation, Mr. McKenzie is going to provide insight and tips on the most frequently encountered survey and accreditation issues that organizations encounter during survey. He's also going to cover the new and revised elements of performance and offer insight on overcoming common misconceptions and obstacles that organizations have in their preparation for Joint Commission surveys. Lastly, Mr. McKenzie will review the most commonly scored elements of performance and ways that deficiencies can be avoided. So with that, I want to introduce Herman. Mr. McKenzie is currently Director in the Standards Interpretations Group at the Joint Commission. In this role, he manages all activities associated with the daily operations of the Physical Environment Department, provides standards interpretation and education to Joint Commission surveyors and accredited organizations, reviews equivalency requests and survey reports, conducts surveys and intracycle monitoring conference calls, serves as faculty for educational programs, and is a speaker for national, regional, state, and local audiences. Mr. McKenzie has over 30 years of healthcare experience, having held managerial and director level roles in clinical engineering, plant operations, and facilities services throughout the Chicagoland area. Previously, he was part of the team that opened the first new hospital in Illinois in over 25 years. Mr. McKenzie is a certified healthcare safety professional, is a member of the American Society of Healthcare Engineering and the Healthcare Engineers Society of Northern Illinois, serving as president from 2013 to 2014. Mr. McKenzie has also been selected as board director for the Association of Advancement of Medical Instruments. Mr. McKenzie earned his Master's of Business Administration from Governors State University, University Park, Illinois, and a bachelor's degree in electronics management from Southern Illinois University, Carbondale in Illinois. Mr. McKenzie is a certified yellow belt. With this designation, he supports the Joint Commission's activities associated with establishing and sustaining a robust process improvement culture. As a certified yellow belt, he is trained in the foundational concepts and tools of problem solving and makes improvements to better meet customer expectations and organization objectives. So with that, we are sharing our screen. Herman has a presentation that he's going to go over with us. And Herman, I'm going to turn it over to you. Thanks again for joining us today.
Thank you. Thank you very much. Hope you can hear me.
Yep, sound great.
All right, folks. So thank you for inviting me to have to speak with you. So for the next hour and a half, or next few moments, we want to talk about, have a conversation about compliance in the physical environment. So go over the learning objectives, the topics. We're going to talk about survey prep and documentation, our standards, new standards and EPs. We're going to talk about some frequently scored observations and new business occupancy standards. Now, I like to couch these in terms of a conversation. And with any good conversation, I want you to feel comfortable to ask your questions. So I'm not going to ask you to wait till the end. Hopefully we can keep this moving along, that we still keep within time, but I'll go over if we need to. So if you do have a question on something, I know sometimes you will forget if you have to wait till the end, feel free to drop it in the chat and I will pause and address your issue. So with that, let me just start talking about survey preparation and documentation. What should you expect? What should you do? So 3 big things. Make sure that you get organized, right? Make sure that you have your documentation and make sure that you understand the standards and the elements of performance. Now, this may sound rudimentary, and I don't mean this to say this to slight anybody, but one of the things I'm going to start that we've been emphasizing recently is you have as an accredited customer, you have a copy or you have access to our standards and EPs. And we do make changes and we do updates. So when you know that you're in your survey window, make sure that you do a thorough review of the requirements. We may have changed something, we may have added something. Some of these things we're going to talk about today, but make sure that you fully know what's expected of you. Also, just a tip, this is going to be a refresher for a lot of us, but if we're new, this may be new to you. When you look at our standards and our elements of performance, especially in writing, you will see that some have a D icon next to it. So what does that D icon mean? That means that it has a documentation requirement. So we need to see that that activity, inspection, testing, and maintenance has been completed. And we need to see it that it's documented. Now, this always begs the question, Herman, where is 2022? We don't carry a lot of paper around. Understood. You can have this requirement, documentation requirement on a laptop or desktop computer. We don't care, just as long as you have the information and you can produce it. So going back to what it says, get organized. If you're an accredited customer, you know to expect us every triennial. It's a triennial survey cycle. So every 3 years. Now, I have to concede, we're still in the public health emergency, and the public health emergency has thrown us off a little bit. But once you know that your window is open, so you have to see within 3 years, but after 18 months, after 18 months of your previous survey, that window opens up. And so we can come back and after 18 months and see you. Once your window opens up, make sure that you're intentional and that you're gathering all your information. I'll give you a tip. I had, one time I was operational years ago, and what I've learned, I learned from not being as prepared as I wanted to for a survey. So what I learned was, once my window opened up, I made sure that I had copies of all the documentation that's required. My team that reported to me that was responsible for gathering this information, we essentially had like a mock document review, survey review. And we made sure that we had all the documentation. And what I did was we all put it in binders. And then each month, if something had a monthly requirement to add to it, we added to the binders, and I kept it in a locked cabinet. And that way, once our surveyors came on site, we went to the cabinet and we knew that we had up-to-date information, and that we did not need to go searching and looking for the information that was required. So that begs the question, what information is required? One of the things that you can do, you can look at the extranet site, and you can see a copy of what I'm sharing with you. Now, I've taken an excerpt of the document review checklist, and you can see to the left the standards and the elements of performance, and then you see the EPs, or EPs, and you can see yes or no to make sure that we have the documentation. And we start here with LS 010101, and that's for the life safety drawings. And it shows you the requirements for the life safety drawings. And then it moves on to our EC, or environment of care requirements. And so I am willing to share this. If I haven't already made it, I'll make this presentation available to the organizers, to Joe and Beth, and they can distribute it to you. So speaking of the documentation, one of the document-heavy EPs, probably the most document-heavy EPs that we have is EC 235. And we have over 20 EPs. And this focuses on your building, your fire, your building and equipment and systems that provide detection and alarming for your fire, So these are the things that we're looking for all the documentation, name of the activity, date, etc. And then make sure that you have a proper inventory and that you're reconciling the inventory counts from the previous inspection cycle to the current inspection cycle. What do I mean by that? Well, let's just say in the previous testing cycle, you showed that you had 75 devices. And in this inspection cycle, we see that there's 90 devices. Well, that's going to raise a red flag for your surveyor. They're going to assume we may have missed 15 on the previous inspection cycle. Now, there could be a very valid reason for the number being different. For instance, You could have had a construction project, you had an addition put on, and so you need additional devices, right? Conversely, you can have a situation where you have less. Maybe you shut down or demolished an area. So there could be a very legitimate reason why you have different device counts. That's why we ask that you make sure that you reconcile those device counts, that you explain them. There's a rational reason, explainable reason why the device counts are different. All right, review your documentation review checklist. I've provided an excerpt here. Make sure that you get any outstanding reports from your vendors, right? If you know that you have a vendor that's done some testing for you, like all of us have, right? Make sure that you get that report. One of the ways that you can hold them accountable, don't mean to be punitive, but don't pay them until you receive it. You are going to be held accountable for having those reports because it's your facility, and we want to make sure that you are keeping that facility safe, right? So make sure that your vendors understand your requirements, right? I get calls and questions all the time from vendors because they said, oh, we have our clients and they're asking for this, or they want that, and they want to, verify, or they want confirmation, or they want some clarity of what's required. And I'm very open about sharing with them, yes, your clients are asking for, their request is legitimate. Please provide it to them. This is what they need when our surveyors come on site. So, couple things within the survey, make sure that value, if something has a value that we need to document according to the code, make sure that we're recording the value. If something has a date, make sure that you, as we said earlier, a couple slides earlier, make sure that we record the date and the proper NFPA reference. And I'm going to pause now because I see I have a question in the chat. Oh, no, it just says, hi, enjoy the webinar. Okay. And I will. I am so far. All right. So let's talk about our documentation. All right. So let's just say, because this happens, right? Our surveyors come very early in the morning. They'll show up probably 7:30. And the document review session is one of the first things that they do. Our teams want to look at your documentation. I don't want to say get it out the way, but they want to address that early in the survey so they can go and do the building tour. So, we all have to deal with real life, right? So let's just say, for instance, you're the facilities manager, director, and you plan on being on site that day, but you have a personal appointment. You got to go to the dentist, or some other personal appointment that you're not there during the document review time or at first thing in the morning. We understand that. So it's not uncommon for our survey team to issue what they will call an IOU. So they will say, hey, Herman, I understand, maybe the part of your team is there, and they say, oh yeah, Herman can get that for you, but it's in his locked office or it's on his laptop, and he takes his laptop home. Understood. So the surveyor may say, you know what? We're going to do what we can in terms of the document review. I'm going to start the building tour. I break for lunch at noon, and I'll be back at 1 o'clock. At 1 p.m., your facilities director should be on site. Make sure that you bring it to me by 1 p.m. All right? Pretty reasonable. Now, what we don't want is a circumstance to happen where that document is not produced by 1 p.m. because the surveyor may not ask for it again, right? They're conducting the survey. And our life safety code surveyors very often are not there the entire length of the survey. You may have a 4-day survey, and our life safety code surveyor may only be there for a day and a half or 2 days. So they may have left. And then maybe the facility director, oh yeah, I was supposed to turn that information in by 1 o'clock at the first day of survey. Well, unfortunately, they forgot and they turn it in after the life safety code surveyor has left. And they give it to a member of the survey team. And so they feel they're in, in the right. Well, unfortunately, by that time, the life safety code survey has already probably documented that this is a deficiency because I did not receive it at the time that I asked for it, by the deadline I asked for it. Now, I'm going to sidetrack a little bit. If any organization feels that a observation was made in error, essentially, you felt that you were compliant at the time you were cited, you can file what we call a clarification. And the reason why I'm bringing it up because you're entitled to a clarification, being one of our accredited customers. I'm bringing it up at this time because if you submit a clarification based off of late documentation, we will not accept it. So if it's a document requirement, the expectation is that you should have it because we've put it in our standards, we put it in our elements of performance. We will also give you an IOU. And so if you haven't turned it in by the deadline established by the surveyor for the IOU, you cannot use that as grounds. You cannot turn it in late and say, well, I turned it in, and use that as grounds for clarification. So we will not accept that. So I just want to make sure everyone knows that little tip. All right, with that, any questions? Once again, any questions, feel free to submit. So I can tell you, and so one of the things that I found, I've done many presentations, usually you need to break the ice. And once, I can tell you, adult learning is interactive. And I can comfortably say in most of the presentations that I do, I learn based off the questions. I learn a nuance or some esoteric piece of information based off of the questions that are being asked. I can also tell you, if you have a question, don't be shy, because if you're struggling with an issue or you have a question, there is more than one person who has that same question or struggling with that same issue. All right, so what's new? Well, this year we have introduced the EC 211 EP17, and that requires organizations to conduct an analysis for workplace violence. Unfortunately, in the times that we're living in, we're seeing high-profile issues, both in healthcare and outside of healthcare. And we're getting more in a good way. Some of the things that went unmentioned or did not get attention is getting attention, especially in healthcare. We have our workers have a hard enough job or challenging enough job without having to deal with a workplace violence. Consequently, the Joint Commission has introduced a new element of performance that requires organizations to conduct a worksite analysis annually. Now, we are not prescriptive on how this should look like. I can tell you though, if your worksite analysis reveals something to be a trend, of course, the expectation is that you will have done something or will take steps to do something to address it. So let's walk through kind of a theoretical example. You're finding out in your registration area, you're having, in your public-facing departments, and let's talk about registration. You're having an increase in incidents, right? And the incidents have increased in the summer months. It's happened on weekends. Let's say this is theoretical. Okay, we've captured the information. Your organization has captured the information. The expectation is now that you've captured it, you've done a worksite analysis, what are the steps that you're taking? All right. Questions that I've received: does the Joint Commission require any specific training for people who work in the emergency department, people who work in registration, people who work for these public-facing departments? No, we do not. However, if you've adopted it as part of your policy and process, we would expect that you would keep to your word or keep to the requirements of your hospital's policy and process. So we're not at prescriptive, with the exception of we expect you to do a worksite analysis. We don't tell you the shape, the form, the format of that. And then if you have certain things, if you revealed in your worksite analysis, as with any environment of care, discipline, or function, we expect that you would take action to address those issues. All right. New water management standard. Boy, we've been talking about this for a few years. We rolled it out, right? We came out with a new standard. Now, we had an EP in the past, just for matter of review, 251 EP 14, that we wanted you to have a program to address waterborne pathogens. And after years of looking at it and examining it, we've come up with a brand new standard, which has 4 EPs. So we've rolled it out. And just to give you an update, these are the requirements of the EP. So I'm calling out that you have to have a program, it's in accordance with law and regulation. One of the new things that we're asking for is you have to have a diagram. I can tell you this is probably one of the #1 questions that I fielded, is that how should that diagram look like? Well, they don't have to be stamped engineering drawings, right? They can be, we don't ask for a level of sophistication, with the exception of capture the issues that we talk about in the EPs. For instance, do I have to identify every single water fountain or every single faucet or shower head? No, you don't. I'll show you an example. You can use a block diagram to represent certain things, certain fixtures, all right? And here's the diagram. This was taken from the CDC toolkit. All right, you can Google this yourself, or online and get a copy, whatever. Or you can, like I said, we're providing this to the attendees, so you can look for it yourself, or borrow from this. And as you can see, it shows cooling tower, the fountain, ice machines. It doesn't call anyone specific. Each doesn't have a diagram for each, but it shows the floors 2, 4, 6, 8, and 10 with their ice machines. All right. Another issue, or another EP, EP3, talks about you need to document all the results of your monitoring activities. So if you've established certain criteria or rubric, make sure that you're doing exactly what you said and that you can show that. This is one of, as I mentioned earlier, about a documentation requirement. This is a documentation requirement. A few months ago, had an interesting set of discussions with a large system, a West Coast-based system, about activities that they were doing. Actually, they were doing certain activities, but they weren't documenting it. And so there was some pushback, but because when we met with them, they articulated a pretty good program. But as I said, they weren't documenting it. So when our surveyor, our field staff went on site, we just couldn't see it. We didn't see it. So make sure you're documenting everything. Make sure that you capture any changes to the water system, right? Or any new or at-risk systems that have been added or removed. Now, this is something I can tell you, this is, the physical environment is my focus, but our clinical team, our clinical surveyors have been trained on this as well. So it's not that only our life safety code surveyors will be looking for this, our clinical staff or our clinical surveyors will be looking at this issue as well. So this is another graphic for you, how we, kind of example how this should flow, establish a plan, describe the system, etc. And so you go through 1 through 7, and it's a continual loop of tasks and assessments that you do. Now, we've just rolled this out, 252, EC 252. So I wanted to get a snapshot of, said, well, since we've rolled it out, what are we seeing on our surveys? And so we have this program that we can run, and you can see the issues in terms of the scoring. Most have been under element of performance 2, and then 3, and then 1. So some examples, right? no documented plan, all right? Let me go back, I'm sorry, I'm gonna toggle back and forth. EP2 is the number one, EP3 and then one. So the organization did not have a diagram mapping supply sources. So you have a documented plan, but it appears that the number one issue that we are running into is that you don't have the diagram mapping supply sources. Once again, it doesn't have to be, you don't have to employ an architect or, a licensed engineer to do this. This is someone knowledge of your plumbing system can do this. And there are standard, I'm not trying to plug any program, but there's standard managerial software programs that you can use that do flow charting and that you can use to do it. Like I said, we're not prescriptive. It doesn't have to be, stamp drawings, but you have to have something that shows. All right. So this ties to the previous EP that we talked about the workplace violence program. With all of the environment of care, there's the management plans that you have to do. Then you have to do an annual, you have to continually monitor. You have to, when you find issues, you have to address the issues or show that you're addressing. And this is what we wanted to make sure we added this for the workplace violence issues. So this just goes along, this should be baked in your program. As you're evaluated all of your environmental care issues, we want to make sure that you're evaluating your workplace violence program. I'm going to pause right now to see if there's, any questions. Okay. All right. So in general, we do a review. You all, meaning our customers, send us questions and comments and feedback on our standards and elements of performance. And if you're like me, sometimes when you know what you're talking about, you don't read how it can be misinterpreted. So there are times where we read what we mean in our EPs, but we depend on you all to give us feedback, and you give us feedback. And so we do make grammatical changes, or there's a COP cross-reference change for, I'm using COP shorthand, but that's condition of participation. We may have had a COP crosswalk, an EP crosswalk to a certain condition of participation, and maybe there's a more appropriate condition of participation that needs to be crosswalked to. The requirement has not changed, because if it did, we will create more attention to it. But we just want to make sure that if our grammatical or sentence structure needs to be refined, we do that. So whenever we do come up with a change, our goal and intent is to give our customers 6 months notice, especially if it's a change that we know that will affect your operations, or that it will affect your resources, an organization's resources, and that you need to address it with more resources. So our goal is we give you 6 months. We put it in the pre-publication standards. So make sure that you check that out. We create a perspectives magazine. So as an accredited customer, you are entitled, you receive perspectives free of charge. Now, we also have EC News. EC News is a subscription service, but once again, if it's something that we're changing, we're going to put it into the perspectives in a perspectives articles. So we would hope that you can go through that. So one of the keys to compliance, one of the things that I said up front, make sure you understand the standards and EPs, read the manual. If you look at periodically, understood, you have your day job, right? But if you look maybe every month, maybe put it on your calendar. Every month, look at a perspectives article or look at any potential changes. They don't come out that often because we should not be making all these wholesale changes, but maybe once a quarter you can look, read our perspectives article, or look on the extranet site for pre-publication standards. The two primary times of the year where we make changes are January 1st, so beginning of the year, and mid-year. So July 1 and January 1 are primarily the times of the year that we make these significant changes. All right, so let's go on to some of the top physical environment observations. Before that, I'm gonna explain something about if you've been, assuming you've been following the Joint Commission for years, my previous title was Director of Engineering. And this spring, we changed it to the physical environment. And actually, I did put out a blog and we did do an article. And the reason for it is we felt the physical environment is actually becoming more standard and industry term for folks in our roles that look at compliance. CMS uses that. Our competitor accrediting organizations use that terminology. And actually, it's more encompassing of what we do. We evaluate the physical environment, or we look for compliance with physical environment codes, right? When we were called the engineering department, I would get it had a connotation to it that wasn't totally accurate. Engineers use the properties of physics, math, and science for design, essentially, and build. And that's not what we're doing. We're not designing or building. In that vein, when we were called engineers, it would not be uncommon for architectural and engineering firms to reach out to our department to do for counsel or to do a plan review. And the Joint Commission does not do a plan review, and we don't provide those type of consulting services for engineering and architectural firms. So actually, I've been meeting with my team and actually, our executives, and we thought, yeah, we like this. And actually, I've gotten some very positive feedback on the name change, and that it really hits home exactly what we're doing. All right, so let's talk about the top 10 physical environment observations. And I looked at this from the year 2021. And you can see the top 10, EC and LS. Actually, if you look at all observations for the Joint Commission, meaning all the clinical, medication management, national patient safety goal, leadership, the environment of care and life safety comprises between 60 and 70%. So let's just call it 65 to 70% of all observations are for the physical environment. And when I speak to folks who are maybe not responsible for the physical environment, this is what I tell them. The reason why we're close to 70% is that no matter what your role is within healthcare, you are affected and impacted by the physical environment, all right? You can be a phlebotomist, you can be a physician, you can be a nurse, you can be an ultrasound tech. You are affected and impacted by the physical environment. If you're a patient, obviously, if you're a visitor, obviously, you are impacted by the physical environment. Once you step on a healthcare campus, a health provider campus, or any deliverer of healthcare, or you are impacted by the physical environment. So that stresses the importance of what we do and how we maintain a safe and healing environment. All right, so let me went through some of these. LS 020135 EP4, and this is, if it's not the top, it's usually in the top 5. Piping is used for automatic sprinkler system, is not used to support any other item. All right. What is that usually, right? It's usually us, we know the rules of the road, so to speak, right? We know that we can't suspend IT cable to the sprinkler pipe. We know that. But in our world, right, we have people from security, We have people from IT that need to go through our walls, right? And to install what? Repeaters, security device, all types of manner of things that actually it's for a good reason, but they don't have our knowledge, right? So what's some good solutions? An above ceiling protocol, make sure that you share this with all the stakeholders, make sure they understand that we just can't go through, you can't have unsealed penetrations, right? Make sure that they can't suspend something. Now, actually earlier this week, I was at the, myself and our two field directors, Tim Market John and Jim Kendick, we spoke at the CSHE annual. And actually someone brought up a good question, said, this being one of our top issues, is there some leeway that we could go to that it's at least, that it's not being suspended? Because currently, if it's touching a sprinkler pipe, we will score it. And I'll tell you, I'll paraphrase what I told him. What's the, you know, the creep, right? Some will say it's not being suspended, it's only touching from the side. That may be very true. So it's touching from the side, and then there you get the creep. Well, it's not touching, it's not resting on the top of the pipe, it's touching the top of the pipe. But what's the difference between resting on the top of the pipe and just touching it? And so you have this means of being so variability that the only way that we can really assure that we're being consistent, if we say, just don't touch the pipe, right? Because one person's touching the pipe is another person's being supported by the sprinkler pipe. So what's the solution? Make sure everybody knows that we just can't do this. And then whenever we're doing work above ceiling, let's put in a process or policy where our contractors know they can't do it. Boy, I've seen that before. Contractor has no idea. Their specialty is in, you know, I install repeaters. I install security, security infrastructure. They have no idea about the life safety code. So make sure our contractors know. Make sure our partners in the healthcare environment know, and make sure that we're auditing after these installations occur. And that before our vendors leave site, if there's something that they need to correct, that they correct it. All right, let's move on to the second one, 255 EP6. So this is our general EP that we have that requires organizations to maintain utility systems. So this is non-critical utility equipment, non-high risk. So this could be, what could it be? Let's talk about it. This is low-hanging fruit. Open junction box, exceeding the maintenance interval on utility, component. You have an air handler that needs to be, do maintenance on it every year, and you've gone a year and a half. You have a fan you're not addressing. You have a fan during the building tour. We see a busted belt on the fan. Even if you have it on a regular schedule, if we see it, we have to cite it. So what can we do? Periodic rounds. I want to say in 2014 or 2015, it's been a while now. It may be 2015, I'll split the difference because it may have happened after that. The Joint Commission stopped requiring environment of care rounds. Remember, we had to do the environment of care rounds twice a year in patient care areas and once a year in non-patient care areas. Well, we no longer have that requirement, but boy, it's still a good idea. It's a great way to manage. When we used to do it, you have a multidisciplinary team, you have a clinical person, you have your infection control person, maybe security, facilities, and we're walking the halls, and we're looking left, right, up and down. And it's also an opportunity to educate staff, because they will see you doing something, but on the spot, you can tell them, this is why we don't allow that. This is why we don't allow corridor clutter. They may not see it as corridor clutter because they're thinking, oh, I have this in the corridor, but there's still a way to walk around it. Well, there's a requirement that you've got to have a certain amount of, a certain amount of space, and they may not know that. So rounds, you can catch the open junction boxes, right? Make sure you have a good computerized maintenance management system where you're being proactive in scheduling the maintenance for all your utility systems. All right, you minimize risks associated with selecting, storing, transporting, using, and disposing of hazardous chemicals. This is another one. No eye wash when injurious corrosive could splash. No weekly check of eye wash. So this is what I get asked. Herman, what's an injurious corrosive? The scale that we use, and you can Google this just to look at what that means in terms of your chemicals that you would come across or the items you would come across. You can Google pH scale, and then you'll see a pH scale. So for us, anything that falls below 2 or goes above 11.5 on the pH scale, and if there's a splash risk, right, we're going to see that you have an eye wash station. So let's talk about it. Now that we've determined that you have an eye wash station, let's talk about the particulars of this eye wash station. So the eye wash station should be able to be accessed within 10 seconds, right? So if we have it behind a locked or closed door, we can understand we probably can't access it within 10 seconds. Now, could an eye wash be behind a closed door? Yes, but not for an injurious corrosive. If you have an eye wash just for convenience, you're not having an injurious corrosive that could splash, that have a splash risk, then yes, you're okay. But for the purposes of what we're talking about here, you have to be able to access it within 10 seconds. Also, make sure you don't have any clutter blocking that eye wash station. In addition, the eye wash station should be able to produce tepid water. What's tepid water, Herman? Well, tepid water is that it will run between 60 and 100 degrees. Up in Chicago, we can't be sure of that without putting on a mixing valve. If you're a more tropical climate, a warm climate, it's probably possible that you can have, tepid water without a mixing valve. What you should do, you should have done some documented formal evaluation or review that it's not required, and you can demonstrate it. Now we have our eye wash. We've got the proper plumbing to it. Make sure that can be activated within 1 second. All right. So it should take 1 second or less to activate the eye wash. And then lastly, make sure that we're checking the eye wash weekly. Now, we reference the ANSI Z58.1 standard, and we reference the 2014 version. And that 2014 version calls for weekly checks. I understand there's older versions that call for a monthly, but that is not what we reference at the central office. So eye wash, make sure we're doing a weekly inspection, make sure we have them where we need them. All right, 261 EP1. And it talks about interior spaces meeting the needs of patient population, safe and suitable for care and treatment. And you can read the rest. This one, we use this for water stained ceiling tile will be the #1 issue. So if we come up into a space and it's apparent that there's wear and tear, and we do not feel that it's excuse me, appropriately maintained for patient care or care and treatment of patients, we will score against this. And I can tell you, water stained ceiling tile is #1. Excuse me. Now, with the water stained ceiling tiles, it's important that it just didn't happen in and of itself. So we always recommend that find the source of the ceiling leak, of the leak. Is it a pipe? Is it a pipe that can be fixed, with a work order? Is it a leaky roof? Obviously, if it's a roof, That's probably a capital project or whatever it may be. So is it a condensation line that you had supposed to be draining somewhere else? And, it got dislodged and it's draining on the ceiling tile, make sure you address it. Now, I can tell you, when we score this, and many times it'd be routine. However, if we score a leaking ceiling tile in a high risk area, right, where it should be pretty clean, for instance, in an operating room, that would be considered high risk because obviously that's a big infection control issue. So, all right, 251 EP9. 251 EP9 talks about labeling shutdowns. But before I get into this, I got a couple questions. All right. Oh, okay, 3 questions. I'll read the first one. If an area with an eye wash station is closed for an extended time, is it acceptable to log as such on the long test before? Yes, that's very reasonable. That makes sense. That makes sense. Great. Actually, that's a great idea, Greg. And I'm thinking more on the outpatient ambulatory sites. I know you may have some ambulatory sites where during the pandemic it was shut down, but yes, or for instance, you have some I've seen this as well. You have med surg units. I've worked at a hospital where we periodically remodel every med surg unit. And so you shut it down. And let's just say you had one in that area. Excellent idea. Yes, it makes sense. Great question. Yasmin Haddad, does Joint Commission have guidelines or EPs for water quality monitoring in sterile processing? No, we do not. Now, AORN or Amy may have some, but we do not have that. So I would check those resources, but in terms of the Joint Commission, no. Now, having said that, I hope it doesn't, I'll provide more clarity. If your organization has adopted some guideline by Amy or AORN and you're not meeting it, what you've established as your policy, then we would cite it. But the Joint Commission does not have those prescriptive requirements. Great questions. What is temperature range tepid? That's 60 to 100 degrees Fahrenheit. Several facilities close hot water so people don't possibly burn themselves. Is it harmful if the temperature is too low? Yes. Without getting into the clinical ramifications, because I have looked this up in the past, there's a reason why we want to have it between 60 and 100. To address your issue, Charles, this is the specific reason why organizations or many facilities put what they call a mixing valve for the eye wash. And so we'll never get too hot or never get too cold. So instead of just shutting down the hot water side for the eye wash, organizations, they just put a mixing valve. I'm gonna guess, I don't have any statistic in front of me. I'm gonna say most organizations put the mixing valve on. Great questions, folks. Great questions, thank you. All right, let me do that and jump back to the presentation. 251 EP9. All right, let's talk about some typical ones. Now, this is very low-hanging fruit. Unlabeled electrical breaker, right? Or the electrical circuit for the fire alarm is not marked in red. Now, I can tell you how this happens. There's probably, if I ask for a show of hands, if I was in person, probably a lot of hands raised. There's always work being done in hospitals, right? It's either a major construction project or a little remodeling. We're adding stuff. We're bringing in new equipment that we need to put in a 220 volt. We're, the director of this department is adding this, so they're adding that, and we're constantly doing electrical work. And our electrician, God bless him or her, they do the work, they complete it, but they don't update the legend in the breaker box, right? Make sure that they update the legend in the breaker box to and the breaker, and the breaker to make sure that we know exactly what we're dealing with. I can tell you, if we find a breaker that is labeled spare and it's in the on position, we are not, well, let me cover this up. We're going to score it as not being properly labeled. Because the assumption is if it's spare, why, if it's labeled spare, why is it on? And this is from our field staff experience, because we've been in circumstances where a breaker's been labeled spare, and then, we go, okay, let's turn it off. And they, organization freaks out, or they've turned it off and it really turned something off and it wasn't a spare. So make sure, I talked about the environment of care rounds. Make sure that if you have electrical, your breaker boxes have appropriate legends. All right, so let's talk about business occupancies. We in July, so we've got a year under our belt now. We started in July of last year scoring business occupancies. And let me give you a little background behind it. I'll give him credit. There's a gentleman, he's since retired from the Joint Commission. His name is Richard, or Dick Gutkeys. And he said, he was working with us in central office, and he said, Herman, we have all these, we're going to these business occupancies. The life safety code addresses business occupancies, but we're not scoring them using, referencing the life safety code. What we were doing is we were scoring any business occupancy, physical environment deficiency, any life safety physical environment deficiency against 2 environment of care EPs. And those were EC 231, EPs 1 and 4. So we were using them as a wild card for these life safety code deficiencies for business occupancies. So we know that the level of protection according to the life safety code is not the same level as a hospital or ambulatory. We get that. However, since it is addressed in the life safety code, we thought, why don't we score against that? All right. You have a blocked exit. You have people hanging, holiday decorations from sprinkler heads or blocking sprinkler heads. Even though sprinklers aren't required in a business occupancy, if you're not taking care of them properly, we should be addressing that. So this is something that we came up with our first iteration last July. And so our surveyors will be surveying the physical environment. So instead of scoring these issues under EC 231 EP4, we're going to score where it rightfully belongs against as a life safety code deficiency. All right. Now let's talk about that. Now there are business occupancies that are part of your hospital's footprint, right? Many times it's the lower level, right? You may have that as the imaging department or some other support department. And we'll go there because it's providing care or support for patients that are inpatient. Now, if that's the case, when in those instances where a business occupancy is kind of part of the hospital's footprint or attached to the hospital, and a campus, our life safety code surveyors are going to look at it. It doesn't preclude a clinical surveyor, but it's really under the province of the life safety code surveyor. And I've given you some examples. Now, the community-based, this is where the new paradigm or the paradigm shift for a lot of folks occurs. The community-based business occupancies, those will not be surveyed primarily by the life safety code surveyors. Those will be surveyed by our clinical surveyors, but they will be applying the life safety code standards and elements of performance. So just I want to let you know that. This gives us an opportunity to rightfully score the things and put them where they need to be. It provides, believe it or not, it provides us a way of educating our customers. Just like I'm running through, I just previously ran through the top 10. I didn't share all 10, but I showed you the top 10, but I ran through the top 5. this gives you an opportunity to look at what your business occupancies are or the gaps in terms of the physical environment compliance and things that you can do to shore up those gaps. So ran through from July last year to this year, so essentially a year's worth of data. And these have been the top LS05 scoring, all right? You can see almost, funny enough, funny, not, I guess not haha funny, but interesting enough, that's a better terminology. Interesting enough, the top scored in terms of number is for sprinkler issues. So you can see sprinkler issues are an issue in the hospital and for business occupancies, even though business occupancies aren't required to have sprinklers, at least not according to the life safety code. Now, I know a lot of, is it a bad thing that having sprinklers? No, actually it's a great thing. And I know many municipalities will require them, even though it may not be required by the life safety code. And so if you got them, we got to look at them. Blocked extinguisher, these are actually EPs and observations that I extracted when I did my research. All right, you can see them right there. Extinguisher, exit door, no exit signs, holes in ceilings, in the land ceilings. These are the type of things that are happening. And with that, you know, boy, that puts in almost just as an hour. Let's take the rest of our time to address some questions.
Feel free to either put your questions in the chat or come off mute if you'd like to ask Herman a question. Oh, there you go.
I'm sorry. Yeah, I think I missed one. If, for example, so I'll address this one. If, for example, housekeeping keeps cleaning chemicals with the pH of less than 2 and greater in their cart that they take around with them, how do you recommend we address this in regards to eyewash station access? Well, it's usually where there's a splash risk. I can see it, and it's usually in a stationary place. So I'm imagining, I would say many of these places where, number one, they should have PPE. But where we've seen it is where you're filling these, and they're usually at diluted levels. But if you're using something that there's an obvious splash risk, so I said that the area, and I said there's a splash risk, you should have some type of eye wash in the area. I have not seen this. This is not typically what we run across. But you know, if this is the case, then you should have some eye wash. Do we need to have meetings for water management? If yes, what is the frequency? All right, Pankaj, I hope I'm pronouncing that correctly. We don't mandate meetings. I would imagine you should have some meetings. So let me tell you some, what have you put in your water management plan, right? I would imagine, so we don't, the EP, nothing in our elements of performance says meetings. However, I don't see an organization having a water management program without having a multidisciplinary approach. So your infection preventionist needs to be a part of that team. Maintenance needs to be part of that team. Some other clinical people. You know, there should be some representation from the house. So I don't see how you could have that without collaborating and meeting. Now, the last time I was operational, we did not have this requirement. However, we did have a requirement for that you have some type of plan for waterborne pathogens. And I'll tell you what I did. I had testing. I had our water treatment company do the testing, and I brought the results of the testing to both the Environment of Care Committee, and I sat on the Infection Control Committee, and I brought them to both of those committees. And I got their feedback. So do we mandate it? No, but I can't see you not bringing it, because I can't see it being a program, a house-wide program, without sharing this to a multidisciplinary group. So I hope that addresses it. All right, if our regular 3-year survey was supposed to be, say, in June of 2020, but we were not surveyed until July of 2021, does the next 18, due to the pandemic, does the next 18 to, it starts based on the most recent, or it reverts? Great question. It reverts back to your original window. It reverts back to your original window. It would be so, and that's a great question, Greg. But if imagine for everybody, it would be so convoluted if we restarted the schedule based on the pandemic. But great question. It goes back to your original schedule. I don't want to miss anyone's question.
There were two up there from, one from Mark and one from Narshima, I believe.
All right, let me go to Mark. Will you be looking at LS drawings for business occupancies? Great question, Mark. We will not be looking at drawings for business occupancies in the community-based clinics. All right. Now, so if you have, now remember I described this, I described kind of, I described kind of two setups for business occupancies. We will not be looking for those in the in your community-based clinics, no. Now, if you have a section of your hospital that's considered a business occupancy, for instance, you know, in the example that I use, the lower level, that's imaging, that should be on your life safety drawings. That is not a hard lift. That's just, you know, that's just a continuation, or that's an extension of what you should be doing for your campus life safety drawings. You know, bear in mind, you know, everything kind of, it's supporting the hospital, it's supporting the healthcare occupancy, it's supporting everything there. It's the same fire alarm system probably. So that's not a heavy lift. But no, we are not looking at drawings for the community-based, because we understand you may be in a medical office building where you're a tenant, and we can't, you know, your landlord, your landlord's not going to give you drawing. We get it. So I hope that addressed your question. All right. Hi, Herman. Can you speak to if there was a workplace violence incident, what documentation is reviewed by the surveyor during the survey? They want to see what you did about it. They would want to see what you did about it. I can tell you, so for those of you who have may not know, we have a department called OQPS, and that stands for Office of Quality and Patient Safety. And that office reviews media notices. They probably have subscription services. That office also is when there's a patient or there's a complaint. It doesn't have to be from a patient. It can be from a staff work. And these, you know, it can be from a staff. It can be from a visitor. For instance, I've had complaints. I've been asked to review. A family member says they've had my dad in his hospital, and the AC went out and it's burning up, and he's 80 years old, and I'm dissatisfied with the response, and I've been asked to review that. We've also had recently, and my colleague Jim Kendick has been on a couple of these surveys where there's been workplace violence and someone has complained, or we found out about it through the media, and we will go on site and investigate, and we will ask, let's look at your workplace violence program. What documentation do you have? What are you doing, and what's your follow-up? So I hope that gives you an idea of our approach to this. I love these questions. Thank you. Fire extinguisher question from Cesar Cortez. Does my staff need to sign the tag the same month our vendor does the yearly. They probably, well, the yearly, you got me right there. I'm going to say right now, Cesar, yes. Yes, because those are two different functions. And they're probably sent them out and send a new tag. And my staff, meaning you have facilities, or the staff that does the regular inspection. That's the context. So yes. Excellent session. Will this content be available in some format to review later? Yes, I'll send this out to the organizers. I'll send a copy of this. I like to review my team. Thank you. You're very welcome. Do we need separate meetings for work? Oh, this is a separate question. Okay, this is kind of an adjunct. Do we need separate meetings for workplace violence, or this can be incorporated in EOC committee? If we need separate workplace violence committee, how frequent we need to meet? We're not prescriptive. Go to the EPs. So you develop your workplace violence program. We don't tell you how often you need to meet for EOC. Believe it or not, you decide that interval. So, but let me give you Herman's opinion. Workplace violence it doesn't only reside with security. It's not just a security function, it's a multidisciplinary, but whoever is overseeing or managing or putting this together, or the lead for this, they should, I strongly recommend that they incorporate some reporting to the Environment of Care Committee, because it falls under the safety and security discipline. So that's my recommendation. We don't tell you how often to meet. We don't tell you how often the EOC can meet. However, whatever this function should report up through there. Another reason why, when you report to this larger committee, you're not operating in a vacuum. You are making sure that everything you're discussing and you're talking about is communicated house-wide. And I hope you have that support. Also, we are really emphasizing now leadership, right? Governing body leadership. And when you report something to the Environment of Care or Safety Committee, I'm not sure whatever nomenclature you use, that should be reported to some segment of your governing body or board of directors. I've been in hospitals where we had a quality subcommittee of the board of directors, and that's all our EOC stuff and safety. It ended up funneling up to them, or going up to them, not funneling down. It ended up going up to them. And actually, on a yearly basis, we had to report to the board of directors. So you have my strong recommendation for that. Did I miss any questions?
All right, Herman, I think you got them all. I really appreciate this, and some great questions. Thank you from our audience members for contributing these. These are really meaningful, and I know we just had our survey about a month ago, and very applicable to a lot of everything you said was checked. So very, very thorough and wonderful presentation. Looks like there might be one more.
Sure. Are there any exceptions completing the maintenance documentation if the organization had a work stoppage or other significant disruptions? So I'm going to reframe your question. All right, work stoppage. There is no allowance for a work stoppage. I can tell you. So that's why I'm going to reframe your question. We are still under the 1135 waivers because we're still under the pandemic. As a matter of fact, that's a timely question. Actually, last Friday, the 15th of July, the 1135 waivers were extended for another 90 days. So we are still they are still effective until what, July, August, from July to August, September, October 15th. All right. When our life safety code surveyors come on site, if you have an inspection, now there were 5 things that, no matter, even with the waivers, that were not waived. Fire extinguisher testing, interim life safety measures, generator testing, extinguisher testing. I don't know if I said that already, but there were 5 things. I've said it so much, but I apologize if I haven't hit all 5. Those things could not be waived. But if you do have a legit, if you are seeking to implement a waiver under 1135 for inspection, testing, and maintenance, let your surveyor, your life safety code surveyor, know in the beginning when they come on site. All right. So the reason why I want to correct the work stoppage, because that's not, I like to use Joint Commission terminology, because in some people's head, they believe they're saying the same thing, but there's really a difference. Because a work stoppage could be a strike, right? Or lack of resources in terms of a walkout. And there's no exception for that. There's no allowance for that. But there are allowances for the 1135 waivers. So, all right, let me get these other questions. I told you once one person asked, it's what are 1135 waivers? Okay, so let's talk about that. I'm going to indulge me for a few minutes, and I'll get this done before our time ends. The Joint Commission is an accrediting organization. All right, what does that mean? Many organizations, healthcare delivery organizations, depend on CMS for reimbursement for Medicare and Medicaid reimbursement. So in order to get Medicare and Medicaid reimbursement, CMS says you have to be providing a standard of care. Your facilities must meet a certain minimum requirement of construction and maintenance, right? Some shorthand. So Herman can't open up I can't open up a hospital and start treating people and get reimbursement from CMS unless I'm accredited. And so CMS has, we are an agent of CMS, and that we provide accrediting services on behalf of CMS. There are a few other accrediting organizations, but the Joint Commission is the largest. We have 90% of all accrediting organizations. There are smaller ones that only do ambulatory, et cetera, but we are the largest one. So in order to be accredited, right, we come on site every 3 years, assuming everything is okay. You know, you don't see us for the next 3 years. So we have our standards and elements of performance. One of the things CMS has is Joint Commission, if you're going to accredit people, we have these rules that your standards and elements of performance must be matched up to. CMS calls their rules conditions of participation for hospitals. For ambulatory sites, they call them conditions for coverage. You will also hear the term COP or CFC for condition of participation or condition for coverage. So I'm going to just talk about COPs. So CMS has COPs that say you must provide a safe, appropriate environment. You must do this. You must have a fire alarm system. It must meet the requirements of such and thus. And I'm speaking generally. We have our standards and elements of performance that crosswalk to the COPs. So not that we wouldn't do it on our own, but we say you must have inspection, testing, and maintenance of your building's fire detection and alarming systems, right? Because hospitals are defended in place. That crosswalks to a CMS condition of participation. All right. So the Joint Commission, when we had the pandemic, our central office head was getting calls. Herman, and then my colleagues, Jim and Tim, all right, the field directors. Guys, no one is coming here. We can't get anyone in. We are restricting people. You're not gonna hold it against us if we can't get this testing done, are you? Well, it was not up to us because our standards and elements of performance were tied to CMS conditions of participation. Now, having that background, CMS can waive those conditions of participation conditionally, permanently, or any variation thereof. And so when there is a emergency, CMS, because they come under the Health and Human Services Department, the secretary can waive a COP. And CMS, effective March of 2020, waived many COPs, not just for the physical environment, but in the clinical arena as well. And so CMS said essentially, now believe it or not, when we were getting these calls, we were getting beat up. And actually, my colleagues and I, Tim, Jim, and I, we put together a document of this is what we think should be waived. I can't say firsthand that they did it just based on us because it made sense to do it. But anyway, CMS issued a waiver, a blanket waiver. Now these waivers, or organizations should have a process for requesting a waiver because waivers are requested almost every year, especially for instance, out west, when you have wildfires, your organization may request a waiver at your regional CMS office. However, because the pandemic was nationwide, CMS says instead of having organizations request 1135 waivers to waive certain conditions of participation, we'll issue a blanket waiver. And so the blanket waiver that they issued were for many inspection, testing, and maintenance activities. And so as long as there's a public health emergency that's in effect, and they've been extending it for 90-day increments, you are still under the waiver. And so as I said a few moments ago, last Friday, the public health emergency was extended for another 90 days. So the corresponding with the waivers being extended for another 90 days. So I hope that addressed it. Oh, and someone sent the link, I believe. Thank you, Herman. It was a great presentation. Thank you. Are non-fire rated doors, particularly in behavioral health unit, required to have a door closer on them? In this case, an observation room door. All right, so are non-fire rated doors required to have a door closer on them? In this case, an observation room door. Well, let me deconstruct this. I could deconstruct this, but let me answer it this way. In a dedicated behavioral health unit, patient room doors are not required to have a door closer. All right, patient room doors, the patient entry doors. They are required to have ligature resistant hardware, including the hinges and the handles. Now let's talk about behavioral health unit outside of the patient room. And let's talk about a day room, all right? A day room. So when you say observation room, I'm not sure how you define that, but I'm gonna say a day room. You have day rooms where there's TVs, or there's rooms where the patients can go when they're not in their room, they can congregate, etc. There's two ways you can handle it in a behavioral health unit. You can make everything in the room ligature resistant, and if that's the case, people can come and go as they freely. Or you have another option. You can make sure you can say, okay, we're not going to go through the trouble of making this day room ligature resistant. However, we're going to equip this room with a self-closing, self-locking door. And that would be for a lot of the rooms that meet that kind of space requirement. In addition to equipping this room with a self-closing, self-locking door, we will have as part of our operations that patients are never in this room unescorted. So patients, if there's a patient in that room and it's not ligature resistant, we got a staff member with them. As soon as everybody walks out that door, it's self-closing, self-locking. So Cesar, I hope that addresses your question.
Well, thanks, Herman. I think that got the rest of them, unless there's any more last minute questions pop in. I really appreciate this excellent information that you shared with our group. And again, audience, thank you for your questions. These were really excellent and make for an even better presentation. It's going to be recorded. So if you're a CSHE member, it's going to be on our website available. Please, as one of you mentioned, share it with your colleagues, with your teams. This is really helpful stuff. So Herman, on behalf of CSHE here, thank you so much for joining us. We hope this isn't the last time we get the chance to have you here and get some further webinars with the group, you know, for updates and things like that. So thank you very much. And thanks everybody for joining. We'll catch you next time.
Thank you all. It was my pleasure.